I would predict the patient would relapse within 5 years because his high MAP score and because the fact that his tumor was 9 centimeters in the abdomen. So it does not surprise me at all the patient relapsed at about roughly 4 years after initial therapy. So then the patient in this case were treated with Ibrutinib. I really love this option. I think it is absolutely the right thing the oncologist in this case did. Ibrutinib is a small molecule targeting a protein called the proton tyrosine kinase, which is the important component of the B cell receptor pathway, all the way from the surface of the B cell until the nucleus of the B cell. And BTK, proton tyrosine kinase, is in the cytosol part of that pathway. And once it's blocked with Ibrutinib, or you knock off the gene out, the cell die. So Ibrutinib was approved in November of 2013 by FDA, US FDA, through the breakthrough mechanism based on only the phase 2 clinical trial that was not intentionally intended for FDA approval. They were just doing a phase 2 clinical trial, but it yielded unprecedented efficacy with a 68% overall response rate and CR of 20%. And you may not think this is impressive, but let me tell you, if you use ICE, you use ESHAP, you use all this chemotherapy combinations, ESHAP, you need to admit the patient to the hospital for that therapy. And the patient will lose the hair, the blood count goes down, they need transfusions, they need to try to fight infections. And now their response rate is about 65 to 70%. Now we can achieve this without giving the patient all these chemical toxins combinations. We do not have to use intravenous catheter. We can just give the patient the pill once a day and he achieve the same purpose. So this was a milestone in the therapy of mantle cell lymphoma. I'm very proud and I'm very happy from inside that I actually led the clinical trial that led to the FDA approval in this clinical trial. And might be one of the top 10 people who prescribed Ibrutinib on this, in the field of mantle cell lymphoma. So Ibrutinib is given at 560 milligrams, which is 4 tablets, 4 capsules. Each capsule is 140. Typically, the patient will take 4 capsules in the morning on an empty stomach. And so after that, the Ibrutinib, the most dreaded, most common side effect is fatigue, loose stools, not qualified for diarrhea, and sometimes with a little petechiae, like aspirin, very common bleeding issues, but nothing severe. If you do not use it with other blood thinners, such as warfarin, such as Xarelto, such as aspirin, if you don't use with those medicines together, the bleeding usually is not very heavy, not very risky. However, you need to caution all the patients who take Ibrutinib, try not to fall. Avoid contact sports, avoid riding the bicycle, because if the patient fall, in that clinical trial, about 4 patients had subdural hematoma, intracranial bleeding. Every one of the 4 patients had 2 things. They were taking either aspirin or warfarin. They were also associated with a trauma such as a fall. So avoid trauma, be aware that Ibrutinib is a bleeder. The other issue is that Ibrutinib sometimes can cause a rash, especially in the young people. And you don't panic, it's not an allergy. You use, stop the drug for a few days, and you use a medical dose pack. It goes away almost all the time. So don't be afraid of the rash, but be aware of the severe bleeding risks. The most dreaded side effect is atrial fibrillation. About 6% of people, especially the elderly people who are above 70, who has a history of long-term hypertension, who has a history of cardiac disease, any of a cardiac disease, ibrutinib could induce atrial fibrillation. Atrial fibrillation, you know, the most dynamic organ of our body is the heart. And the heart can decide the patient's life in minutes or seconds. Therefore, when the patient had atrial fibrillation, so according to my experience, I would avoid using ibrutinib. This is not the general guideline you would hear, but I become very cautious when the patient has atrial fibrillation. I often ask the patient to have a nodal ablation from the cardiologist. Well, nodal ablation is not a regular indication for this kind of atrial fibrillation, but oncology is changing the culture of cardiology. And many cardiologists are collaborating with us to put the patient into normal sinus through nodal ablation so we can resume ibrutinib. I once treated a 85-year-old lady from Texas. There's in Houston, there's a very much traveled local road called the Buffalo Speedway. She lived on that Buffalo Speedway, which is 5 minutes away from MD Anderson. She received stem cell transplant, hyper-CVAD, everything under the sunshine, she got it. And then she came to me in about 2015 and was put on this clinical trial that led the approval of FDA for ibrutinib. I remember she has the tumor on the right side of the cervical, and a big tumor like an apple. Within a week, the apple became a golf ball, and within 2 weeks, the apple disappeared. So a good complete remission occurs 20% according to the old testing criteria. If you use the Lugano new updated criteria, called the Lugano criteria, the CR rate will be much higher. It will be about 30 to 40% to the best of my knowledge. So complete remission does happen if you use PET scan. PET scan negative, we call it a complete metabolic response. And so the response is about 70%. And if you are able to steer the patient away from these toxicities, and the patient could stay on the drug for as long as 5 years, my record is 6 years.